very good evening to one and all. I'm Dr. Sajal Kamath. I'm an endocrinologist in Pune, and I would like to welcome all of you to yet another ESI Facebook Live session. And today we are going to discuss one of the most rampant epidemic in today's world, and that is obesity. Along with it, we would also be discussing about dyslipidemia or disorders of lipid or cholesterol, like you commonly call it. So these are two of the most common diseases that we as endos come across. So most of you uh, have these on your mind. मुझे cholesterol है. What is good cholesterol? What is bad cholesterol? And what better an opportunity than to get to know about all these things, get your doubts cleared with the endocrinologists themselves. So, today we are going to have a discussion with four eminent endocrinologists of India regarding the same topic, obesity and dyslipidemia. I would like to introduce to you all our four panelists for today. I would like to welcome Dr. Milind Patwardhan sir. He is a senior consultant endocrinologist at Endocrine and Diabetes Research Center, Miraj. He has multiple publications in national and international journals. He is also the author of Madhumeha, Mantra and Tantra. I welcome you, sir, to this
You.
discussion.
Thank you.
Next, I would like to welcome Dr. He is a senior endocrinologist at Jain Super Speciality Endocrine Center, Surat. I welcome you, sir. Next, I would
Hello.
like to introduce and welcome Dr. Vijay Bhaskar Reddy, sir, who is the founder and senior endocrinologist at Vijay Diabetes, Thyroid and Endocrine Center, Puducherry. He is the president of Puducherry Diabetes Research Forum and also the secretary of Endocrine Society of Tamil Nadu. I welcome you, sir. Welcome to the show. Lastly, I would like to introduce Dr. Anish Behel, sir. He is a consultant endocrinologist at Apollo BGS Hospital, Mysuru, and he too has multiple publications in national journals and also has been the principal investigator for many clinical trials. Welcome, sir. So I welcome you all to this live discussion, and we are going to discuss about one of the most common topic, that is obesity या मोटापा जिसे कहते हैं, and dyslipidemia या disorders of lipids या cholesterol in layman term. So I would like to begin the discussion by asking Dr. Milind sir, what is obesity and how do you define it in terms of BMI, sir? Would you like to tell the audience that?
Yes. Thank you, Sajal. I welcome all the audience. So this obesity is a very important topic. People talk about it as a motapa, but people don't have full perception or understanding of it. If you ask somebody, who comes for obesity clinic, if you ask, घर में और कोई ऐसा है आपके जैसा, तो दे विल आंसर यू, हमारे घर में सब लोग ऐसे ही हेल्दी है. So they feel the motapa is nothing but health. But obesity is nothing but excess fat accumulated in the body and which can be detrimental to the health. And as you can easily understand that nobody becomes obese in one day. It's a slowly growing chronic progressive disease, and therefore there has to be arbitrary cutoff line. But the cutoff lines are not absolutely arbitrary, they're related to some health consequences. For example, in 1901, the metropolitan data of LIC companies, got published, and it showed that weight is related to longevity. So since then, people were after to find out what ideal weight should be there for the person to have maximum longevity attributed to his height. So height and weight was being connected, and multiple indices were being tried to find out something which can be logically found out. So many things were tried, but nothing was clicking. But ultimately, Dr. Ansel Keys found out an old index called as Petlet index. It is BMI or body mass index. So something which measures both your weight and considers your height should be used to find out what is your mass. But as you can understand, it's a total weight. It is not going to tell you what is the fat mass versus non-fat mass. And secondly, it is not going to consider whether you are male or female, what is your age, where are you from, which race you belong to. So in short, this index, which is body mass index, will give you an idea of mass or weight, whether it is in excess or not as compared to the given height. सो बॉडी मास इंडेक्स हम जिसको कहते हैं वो आपके वजन और आपके हाइट को कंसिडर में लेके एक इंडेक्स आपको दे देता है. इट इज़ वेरी इजी टू कैलकुलेट. यू टेक योर वेट इन किलोग्राम्स एंड डिवाइड इट बाय योर हाइट taken in meters squared. That means your height, say weight is 60 kilo and your height is 160 centimeter, then it becomes 60 divided by 1.6 multiplied by 1.6. So like that, if you calculate for 160 centimeter person, 60 kg weight becomes 21.3 BMI. If the person becomes 65 kg in weight, the BMI comes out as 23.3. Like that, so once your height is fixed, your weight mainly produces the change in BMI, and therefore BMI is a rough index of how much weight is increasing as compared to your height. Mostly it definitely tells you about your total weight and not necessarily only fat weight, and therefore it is a rough index, but still it is a good index, because what was found that the mortality is minimum with BMI of 23 to 25, and below 23 and above 25. On both sides, you get the U-shaped curve telling you that mortality is more with more BMI as well as low BMI, and therefore ideal or desirable body mass index can be predicted, can be advised. So this is something by which simple you can measure obesity. Is it okay, Sajal?
Yes, sir. Very truly said, very well described. And one thing which I really, which we come across, sir, कि when you ask the patient कि is anyone else ऐसे ही है, तो ये बोलते हैं कि हाँ हमारे घर में सब healthy है. It's very commonly we get. So it's very necessary that people understand what obesity is, or the difference between being healthy and being obese needs to be understood. So, with that, I would like to move on to my next question, and I would like to address it to Dr. Ajay Jain, sir. So,
Yes.
sir, is BMI the only indicator of obesity? So, just now, sir spoke about BMI and how to measure it. So, we do measure it in most of the cases. So, is that the only indicator? How accurate is this BMI? Can it be falsely high or falsely low in any cases? And what are the other measures by which we can measure obesity, sir?
So I think Sun has very nicely explained regarding body mass index. We to measure the weight in a person, we are having various parameters. One very important is body mass index. It is very simple to calculate, and outside clinic also we can do this test. But the only disadvantage of this test is some person can have normal body mass index, still he is having central or abdominal obesity, and in that case we are not able to pick up, and this problem is more common in our Indian patients. So we can also take care of other parameter. BMI is a good parameter. It will tell you the fat content of a person, but other parameters to take weight, whether the person is fit or fat, we are having like waist circumference, waist hip ratio, we are having like skin fold thickness, and very accurate method which are generally used in the research purpose are DEXA scan and CT and MRI. As sir has told exactly, हमको पूरा BMI के बारे में तो सर ने बता दिया, पर waist circumference it is also very easy to take. You only require an inch tape. If I tell regarding a lay person, मैं एक lay person को कहना चाहूँ तो अपनी just belly के ऊपर ही वो एक inch tape रख के अपना waist circumference ले सकते हैं. But in a medical term, if we are taking in between of lower end of the of the ribs and upper end of the hip. In between, if we are taking, and it comes roughly around our umbilicus or just above umbilicus, we can very easily pick up. Waist circumference is also very accurate as BMI. It is reproducible also, and it is very easy to take. If a waist circumference is more than 80 in a female or more than 90 in a male, then this I am talking regarding our Asians, to they are having obesity. So waist circumference is one very important. Waist hip ratio second we can take, but in this waist hip ratio we take at the highest point of waist and highest point of the hip, and then we divide. So here there are 2 points, हमको दो चीजों को डिवाइड करना पड़ेगा, तो गलती होने के चांसेस बढ़ जाते हैं, बट स्टिल इट इज ऑल्सो वेरी एक्यूरेट एंड इट टेल्स अस रिगार्डिंग द बॉडी फैट कंटेंट. It is as accurate as BMI, waist circumference, waist hip ratio. One thing I want to say like this: whenever a patient visit to our clinic, at every visit we should do its BMI and waist circumference. If it is not possible, once in a year we should do this BMI, or say or this waist circumference. We are having difficulty in doing it at our clinic. Other methods which are available is like skin fold thickness. This is also very simple test. It only require a caliper. It requires, which is not very costly, and there various tables are available. We fit the value and that we can calculate. We most common site we are doing at subscapular level, or we are doing at the tricep level or at the thigh level. By this also, and DEXA scan, CT scan, and MRI generally they are done in research purpose. They are very accurate. They tell us clearly our bone mass, lean mass, subcutaneous fat, and abdominal fat. So they are generally done in this. But I think, and I think everybody will be agree, and Dr. Milind sir can also comment. If I think waist circumference plus BMI both can do in our day-to-day practice. Yeah.
I just wanted to add one more thing, that
Yeah.
WHO in 1990 declared that BMI of 25 should be taken as a desirable, and from 25 to 29.9 as overweight, and from 30 onwards,
Yeah.
obesity was defined. Now, since
Yeah.
long time Indian physicians were finding out that even at low BMI, our people have metabolic abnormalities, more incidence of diabetes at early age. So they insisted that we should have lower cutoffs. So initially in 2000, WHO agreed and said that we should have lower cutoff values for the Asians. But in 2004, WHO said that you should use same standard, that is Western standard for everybody. But for local population, you can have your own bodies and find out what is the ideal or desirable weight for your population. In 2009, the consensus opinion of Indian physicians has come out with the criteria which we still follow, and we believe that 23 to 25 is the overweight BMI, and 25 to onwards is the obesity for Indian people and Japanese people also. So we in India follow normal weight should be desirable weight should be 18.5 to 23, from 23 to 25 as overweight, and from 25 onwards obesity. Same is as Dr. Ajay said, taking waist circumference is a very important parameter, because that is what measures the metabolic area of the fat, that is abdomen. And even in Western society, 102 centimeter and 92 centimeters are taken as cutoff values for males and females. But as you said, in India, we take 90 centimeters for males and 80 centimeters for females as cutoff values. There are no gradations of western, I mean west circumference. You don't have grade 1, grade 2 in west circumference. More than this is sufficient to say that metabolically active adipose tissue is present in abdomen. So that is what is more important. We are going to come to that discussion. We'll go along the flow.
Thank you, sir. Thank you for the description. So I would like to tell one more thing to the audience. So this month we are dedicated it to men's health, and since we have dedicated this month to men's health, There's one specific question I would like to address to Dr. Anis sir. So, I would like to ask you, how does obesity differ between men and males and females? So, would you like to give your comments on that?
Yeah, thank you, Dr. Sajid. Yes, there seems to be a significant difference between men and women when it comes to obesity. Over the last few years, we have a lot of new information which is pouring in, which is becoming available to us, which shows that there seems to be a lot of gender differences between men and women. Now, studies have shown that women tend to have a greater burden of obesity compared to men, almost two times higher prevalence of obesity and overweight amongst women compared to men. And even the central obesity or the abdominal obesity, which we have been talking about, where there is increased deposition of fat in the abdominal compartment, and that is the one which is responsible for all the complications that we see with obesity. That also is about 2.5 times more common in women compared to men. Even going further, if there is risk related to obesity, whether it is a physical problems or psychological problems, all tend to be more common in women. Even mortality is much higher in women who are obese compared to men. So overall, I would say that probably when we talk about obesity, the burden tends to be much higher in women than in men. Now there are a number of reasons why this could be. uh, Besides the biological reason, there are other such, I would say, social or cultural reasons which could be contributing to a greater burden of obesity in women. One fact is that culturally, or societally, a lot of women tend to be limited to their areas. They're not very physically active, and they tend to be more homebound compared to men. That's one factor. uh, the studies have also shown that women tend to have greater amount of craving for food compared to men, and that could be one reason why the food intake tends to be more in women, and that contributes to obesity over a period of time. And then you have uh, a risk factor, especially during pregnancy and lactation, where a lot of women tend to put on weight, and this could be because of the fact that our there are cultural reasons where women are asked to eat more, plus they're asked to limit their physical activity, and all these factors tend to aggravate over a period of time. So by the time they reach their mid 30s, the burden tends to be quite huge in women compared to men.
Thank you, sir. So, very truly true, sir, that women tend to be more obese than, or are at more risk of obesity than males. And like you rightly said, there are social and cultural factors which play a very important role in this. So again, awareness in this aspect is becomes very important in women, their families, and everything. So with that, moving ahead, um Vijay sir, what we spoke about obesity, the BMI, the measures of obesity. So, what are the long term effects of obesity? Would you like to elaborate on that?
Thank you, Dr. Sajal. I think we have already discussed that obesity, which is excess fat, is not actually healthy. So it's not a sign of, previously it was considered a sign of prosperity, but now it is not a healthy sign. Excess fat is bad. So there are a lot of consequences of obesity or excess fat. We can divide these consequences because these consequences can affect the quality of life and the overall health and well-being of the person. So we can divide the health consequences of obesity into three-fold. One is we can have mechanical effects. Second is we have metabolic effect or disease effects. And third is we have psychological or psychosocial effects. So mechanical effects we can understand. Person is obese, patient is fat, so they're putting excess weight on the body. So the mechanical effects are, one is excess weight on the knees, which is called the osteoarthritis or wear and tear of the knee joints. Then we have excess fat does not support the veins in the legs, and so much pressure causes varicose veins. And excess fat in the neck and the tongue area causes obstructive sleep apnea. Excess fat in the tummy can push the acid inside the chest, causing reflux disease. So these are all mechanical complications which we can understand. So we can have wear and tear of the joints, we can have of the knee joints, especially varicose veins, reflux disease, and we can have obstructive sleep apnea. So these are all mechanical complications. Then we have metabolic complications. Excess weight is associated with the fat in the abdomen is not a very silent fat. It's very active, produces various substances which causes uh, di- problems with glucose metabolism and blood pressure also. So the excess fat causes these obese people to be uh, having more diabetes, high blood pressure, heart disease. People also have gallstones, high uric acid levels, occurrence of stroke. So there are some, and even some cancers like gallbladder cancer, and in ladies endometrial cancer. All these are much higher fold, and that is why obesity has to be taken seriously. Then we have psychosocial factors. We know that obesity is a social stigma. So, person who is obese or fat has got the social stigma. They tend to be isolated by their friends. They are teased by their friends. In schools, also, children who are obese are bullied by their friends. So, this causes a severe social stigma. It causes depression, and it affects the overall well-being. So that is why obesity has to be taken seriously because of the mechanical effects, metabolic effects, and psychological effects.
Thank you, sir. Thank you for the elaborate description. So we have discussed that obesity is unhealthy. So Milind sir, there is this concept of metabolically healthy obesity. So does it mean that if I'm obese but metabolically healthy, I do not have any chances of developing any consequences, any long-term consequences of obesity, as Vijay sir has described in future, or how? What do you want to say about this?
Yeah. Now, before I directly answer you, I would like to talk about two things. One is subcutaneous fat and intra-abdominal fat. The difference. What is the difference in these two? The subcutaneous fat are small fat adipocytes, small in size. Therefore, they maintain their insulin receptors and insulin sensitivity, and they are not metabolically, you can say, active in the whole metabolic milieu of the body. They produce some local cytokines, but the intra-abdominal fat has got limitations about adipogenesis. So when the intra-abdominal fat starts increasing, it starts mainly increasing in the size of the adipocyte and not in the number of the adipocytes. And when the size of the adipocyte increases too much, it sends the signals to the macrophages to invade inside. Plus, the enlarged adipocytes gets hypoxic and starts sometimes dying, and because of its dying, some signals and cytokines are liberated, which attracts these macrophages, which come rapidly and try to engulf the fat cell which is dying. And during this engulfment, the macrophages become what we call foam cells, and they also produce a lot of inflammatory cytokines. So, in short, the metabolic aspects of the intra-abdominal fat are that they are inflammatory or pro-inflammatory cytokines which produce a lot of inflammation, vascular or endothelial problem, insulin resistance, and that is what Sajal said about metabolic health and metabolic unhealth. So if you are basically or mainly subcutaneously obese, your fat is mainly on the limbs or below the skin and not much in the abdomen, then you are probably obese, but you are maintaining good metabolic health. On the other hand, if your fat is mainly in the abdomen, you are going to produce many cytokines and pro-inflammatory cytokines or markers, which are going to produce dyslipidemia or changes in the lipids. They are going to produce insulin resistance, so you are going to become prone to diabetes, metabolic syndrome, hypertension, and vascular disease, that is ischemic heart disease. Now, what happens is there are many phenotypes, at least four phenotypes identified. Phenotypes means presentation of obesity in a population. So, some people will be obese but completely healthy. Some people will be obese, have abdominal obesity also, but still will be healthy. Some people will be of normal weight and yet they will be unhealthy. And some people will be obese as well as abdominally obese as well as unhealthy. So, this is a range of progressively progressing type of you can say journey or trajectory of a obese person. So if you take metabolically healthy obesity, which may mean that at present you don't have any metabolic abnormality, you are obese, but you have still no insulin resistance, no hyperinsulinemia, no hypertension, no dyslipidemia. You are lucky, fine. You are young, you are doing exercise, good. But that doesn't mean that you are going to be healthy all the time. So, metabolically healthy obesity is a forerunner of metabolically unhealthy obesity. In the EPIC follow-up study, it was found that about 43% of the metabolically healthy people within 2 years they become metabolically unhealthy. And if given 10 years of follow-up, then nearly 70 to 80% of so-called initially or beginning with metabolic health become ultimately metabolic unhealthy. So let us not pass on the impression to the general public that if they are obese and have not yet got any problem, then they are safe or healthy obesity. It is nothing like that. They are going to become unhealthy sooner or later. So they also have to take similar precautions. They have to also do diet control. They have to start exercising. They have to reduce their BMI. They have to reduce their abdominal circumference. And even 5% reduction of body weight can produce lot of changes, like decrease in the 5% of body weight decreases your insulin resistance, improves your glycosylated hemoglobin by 0.5%, decreases your systolic diastolic blood pressure by 5, decreases your LDL cholesterol by 30, and increases your HDL by about 3 or 4 milligram percent. Now, coming to metabolically healthy, but those who have not yet become unhealthy, they should keep on checking their metabolic health periodically. So, what they should check? They should check their blood sugars and insulin level in the fasting state. They should check their lipidograms to find out whether any different type of dyslipidemia they are acquiring, and they should check their C-reactive protein or IL-6, which is a marker of inflammation. So these three sets should be seen yearly, even in metabolically so-called healthy obesity, to track them whether they are in the right path or not. So this is what something about metabolic health. But basically, the message is that obesity itself is unhealthy, and everybody should be aware of it and take precaution.
So this means that obesity is unhealthy,
Yes,
and like you said, sir, metabolically healthy obesity, or the term that we use, is definitely a forerunner towards a metabolically unhealthy obesity. So the
yes,
precautions of obesity, healthy, unhealthy, doesn't matter, has to be the same.
that's right.
So, Ajay sir, moving on to you. We just discussed that obesity can lead to dyslipidemia. Also,
Yeah.
बहुत पेशेंट्स हमारे पास आते हैं saying, मुझे कोलेस्ट्रॉल है, ये बैड कोलेस्ट्रॉल क्या है, ये गुड कोलेस्ट्रॉल क्या है. So would you like to tell the audience ki what are the various lipid abnormalities that one should watch for?
Yeah, yes. One thing in obesity is we are seeing the metabolic health. If you will see, 25% of the obese patient can be metabolically normal, and 75% will be metabolically abnormal. They will having, so the what are the various dyslipidemia which are present in obesity is generally what we see is increase in triglyceride concentration. A triglyceride should be less than 150. They are having high triglyceride, they are having high free fatty acids, they are having increased LDL cholesterol, they are having increased small dense LDL, and good cholesterol, that is HDL cholesterol, they are having a reduced amount of good cholesterol. Good cholesterol generally we take 40 in male and 50 in female. So they are having generally low cholesterol, low good cholesterol, and due to this low good cholesterol, they are more prone to various cardiovascular problems. So generally, but one thing, एक और बात मैं कहना चाहूंगा एक ओबीस पेशेंट को अपने सेकेंडरी कॉजेज भी रूल आउट करने चाहिए. They should rule out that whether they are hypothyroid or not. They should rule out CKD तो नहीं है उनको. Are they on any drugs like steroids, diuretics, beta blocker? which can also change their lipid profile levels. So generally, and ApoB concentration is also high. So these are the various dyslipidemia generally we are seeing in our obese patients. And as Dr. Sir has told, we are doing these routine investigations and we are trying to pick up these patients.
Thank you, sir. So this is the next question I would like to address to Vijay sir. So this we get a lot. A lot of patients do ask us. Patients come to us saying my weight has increased because of hormonal imbalance, and specifically patients are concerned about thyroid hormones, yeah, TSH, saying मेरा TSH बढ़ा है, my TSH is increased, so that is why my weight, I'm not able to lose weight, or my weight is increased. So, sir, would you like to elaborate on the role of hormones in obesity?
Yes, Dr. Sajal, I think that's a most common question which we get in our clinical practice. Uh,
Yes.
Although hormonal causes are well known to cause obesity, but clinically, other aspects like excess food intake and reduced physical activity are the main drivers of obesity than hormonal causes. Hormonal causes are less common causes of weight gain, and mostly we have low thyroid hormone, that is hypothyroidism, and excess steroid hormone. These two cause most of the weight gain, but we do not get too much weight gain with mild variation in the thyroid level, like mild borderline elevation of TSH does not cause obesity. But often you find in clinical practice that patients and persons don't want to take responsibility for being obese or overweight. They blame it on, sir, my thyroid is the cause for my weight gain. And finally, you see TSH normal up to 4 or 4.2, TSH would have been 5, and they would have been prescribed the medicine. And patient is thinking that all the weight is because of the thyroid. So we need to be clear. Borderline variations in thyroid levels do not cause significant weight gain. Maybe you will get 2 or 3 or 4 kilo weight gain maximum. So we need to address this with our patients, and people should understand that marginal variations in TSH are not the cause for weight gain. It is just blaming the responsibility on someone else when the actual problem is with food intake and sedentary lifestyle. So this we need to highlight. And steroid hormone problems can cause weight gain, and most often they are actually because of exogenous or taking the medicine from outside. Steroids are commonly used for skin allergies, joint problems, and breathing problems. And over the counter, these medicines are used very commonly. So we should be careful about taking these medicines, especially over the counter medicines. And hormonal causes, although they are one of the causes for weight gain, they are not the common causes. More common causes are uh, sedentary lifestyle and excess food intake. Marginal variations in thyroid may not be the cause for weight gain, and we need to be alert about them.
Thank you, sir. Thank you for clarifying this, because this is something very commonly patients are concerned about, or a lot of people tend to blame everything on thyroid. But this, thank you for the clarification, sir. So, next question I would like to address to Anish, sir. So, there is a common saying कि obesity is not because it runs in family, but it occurs because no one runs in family. So lifestyle modification, from this we know that lifestyle modification like diet and exercise are one of the most important aspects of management of obesity as well as management of dyslipidemia. So what are the dietary and lifestyle changes that one should adopt? Also, one specific question: does diet and exercise directly alter the lipid profile, or is the change in the lipid profile a consequences of weight loss? What is your take on this, sir? Sir, you're muted, sir. You have to unmute.
Sorry for that. Dr. Sajal, what you said is quite correct, that what we eat and what exercise we do has a fair amount of impact on our lipid levels, on our weight. Now, what we need to understand is that if our diet is rich in saturated fat or oil content, and there is increased amount of cholesterol in the blood, definitely that is going to increase the cholesterol levels in the blood. Similarly, trans fatty acids, which are very, very common in processed food, also tend to increase the LDL cholesterol, which is the bad cholesterol. And they also have an impact in reducing the HDL cholesterol, which is the good cholesterol. The processed food, especially if you are having too much of refined carbohydrates, too much of sugars, too much of starches, that also has an impact on the lipid levels, especially on the triglycerides. If the diet is very rich in added sugars, the triglycerides tend to increase. And finally, fructose, which is a very common ingredient of a lot of processed food, also tends to increase triglyceride levels. Now, at the same time, all these factors tend to have a negative effect on the lipid levels. There are certain positive things. For example, the dietary fiber that is present in a lot of fruits, a lot of legumes, a lot of vegetables, that tend to have a positive effect on the lipid levels. It tends to reduce the lipid levels. Phytosterols, which are also present in lots of vegetables and fruits, also tend to have a positive effect on the lipid levels, wherein there is reduction in total cholesterol, because it tends to inhibit absorption of cholesterol from the gut. Now, so when a patient is embarking on a diet because his or her lipid levels are high, so what we normally tell them is that you need to reduce the intake of total oil intake, especially the saturated fat like ghee, should be reduced in your diet. At the same time, you need to cut down on the processed food, especially the fast food, which is becoming so popular these days, and you need to increase the content of contents like nuts, fresh fruits, vegetables. Now, all these factors would have a positive impact in reducing your total cholesterol, reducing the LDL cholesterol, which is the bad cholesterol, and also reducing triglycerides, which is again a form of lipid in the blood, and increasing the HDL to some extent. But if one has to talk about one particular activity which is helpful in increasing the good cholesterol, that is the HDL cholesterol, it is exercise. You need to have a moderate intensity exercise for a significant period of time to have a positive impact on the HDL cholesterol, that is a good cholesterol. In fact, uh, moderate intensity exercise is the only way you can increase your HDL cholesterol levels. We don't have too many drugs which can increase HDL cholesterol or the good cholesterol. We don't have too much of uh, I would say food changes which can do that, but moderate intensity exercise can make a positive impact. Now, weight reduction per se can have the same kind of impact, wherein you can have reduction in total cholesterol, triglycerides, and there can be increase in HDL cholesterol. At a given point of time, it's kind of difficult to say that what amount of lipid changes because of change in your food intake or change in your eating pattern, change in your exercise pattern, or weight loss. Because when somebody embarks on a weight loss program, they naturally have to reduce their food intake, watch what they're eating, they have to increase their physical activity. So it's a sum total effect of all these factors: what diet you eat, what exercise you do, and how much weight you lose. That is going to have a positive impact on your lipid levels.
Thank you, sir. Thank you for elaborating on the role of diet and exercise in treatment of obesity as well as dyslipidemia. So, my next question, Milind sir, um, could you brief our audience a bit about the role of drugs in the treatment of dyslipidemia?
Okay. See, why we want to treat dyslipidemia? Because dyslipidemia is connected to atherosclerosis, a disease in which the arteries become small and the blood supply to the heart becomes jeopardized. So you want to avoid heart attack, for which you want to decrease the atherosclerosis, for which you have to treat dyslipidemia. That is number one. Secondly, if you find out what is the common ultimate final pathway by which atherosclerosis is triggered by dyslipidemia, it is by LDL particle. When LDL particles become small and dense, it can easily penetrate into the blood vessel where it stimulates the atherosclerotic plaque. So, final common pathway being LDL, and as Dr. Bell said, mainly what we find is increase in the triglyceride and decrease in the HDL. How is it translated into the dense particle size? So what happens is that there is a very intricate mechanism by which the triglycerides keep on exchanging their triglyceride molecules with the cholesterol esters of the HDL as well as LDL. And in that process, the HDL and LDL both become small and dense, small and dense. The small dense HDL particle is excreted by kidney, and therefore there is decrease in the HDL number, or HDL goes on decreasing. While small dense LDL particles, they become easily penetrable, and they penetrate in the subepithelial area. They are also easily oxidizable, and therefore they are the cause of the atherosclerosis. So even if dyslipidemia at face value looks hypertriglyceridemia, we do not treat hypertriglyceridemia by drugs in obesity. Dyslipidemia in obesity should be treated by diet, exercise, which is going to affect triglyceride and HDL. But to prevent its consequences of atherosclerosis, we have to use statins only. Are the drugs which will prevent the LDL induced atherosclerotic plaque formation, and later on even plaque rupture, endothelial health, and everything. So, statin is the mainstay of treatment of dyslipidemia, or common called as atherogenic dyslipidemia, which occurs in both diabetes, metabolic syndrome, simple obesity with or without diabetes. So, statin is the mainstay of treatment. You have to start the patient on statin if he has underlying cardiac problem. If he doesn't have underlying cardiac problem, but he has obesity and age more than 40, family history of ischemic heart disease, then also you have to start statin. So you start statin and go on increasing the statins in the dose till you reduce whatever LDL patient has by 40 milligram or 1 millimole. So if you reduce LDL by 40 milligram, you reduce the percentage of ischemic heart disease by 20%. So this is very important. That first you start with statin, you increase it in sufficient dose. If statins in sufficient dose are not helping patient, you can go on adding the drugs which are meant in the line of cholesterol treatment, like ezetimibe, PCSK9 inhibitor, or bempedoic acid. And only when triglyceride values are more than 500 that you think of drugs to be added or not to the treatment. So if triglycerides are more than 500 or especially more than 750, are likely to produce pancreatitis, and for that you add fibric acid derivatives like fenofibrate. So otherwise triglycerides by themselves don't need any treatment. What you need is statin, which will prevent the damage produced by the triglyceride only. So this is what the drug treatment. But underlying diet, exercise is the most important treatment in the obesity, dyslipidemia also. I think that Anish has already told about it.
Thank you, sir. Thank you for giving a brief knowledge about the drugs and how to treat what lipid disorders need to be treated. So, Vijay sir, so this is one frequently asked question. A lot of patients ask me, uh, and the audience needs to be clarified regarding this. So, what is the role of liposuction in the treatment of obesity? A lot of patients come and ask me, "Ma'am, मैं liposuction करा लूँ, मेरा obesity कम हो जाएगा क्या? उससे क्या होगा?" and all that. So, does it really have any role in the obesity per se, in the treatment, in the consequences, anything, sir?
I think that's the most common question which is asked by people coming for consultation for obesity. So we need to differentiate weight reduction surgery from liposuction. So weight reduction surgery or bariatric surgery is actually we have restrictive procedure and malabsorptive procedures. So restrictive procedures reduce the food intake, and malabsorptive procedures they block the absorption. Whereas liposuction is actually only sucking out the fat, as the name suggests, it's just sucking out the fat. So it's not a weight reduction surgery, it is only a body contour changing. So you remove little fat from the abdomen, so that is so you get your tummy tuck. So it's only a sucking out the little bit extra fat. So liposuction can be done for the tummy, it can be done from the arms, it can be done for the thighs. So wherever there is excess fat, it can be sucked out through various techniques. It can be sucked out. So you can get maximum only 1 or 2 kilos weight loss because you're not going to suck out huge amount kilos of fat in this procedure. So liposuction is actually is a procedure which can change the body contour. It can remove fat from specific areas of the body. It cannot be considered as a weight loss procedure because the weight loss surgeries like restrictive surgery where you remove 80% of the stomach or malabsorptive procedures, they can give you up to 50% weight loss. 50% weight loss in a 100 or 120 kilo person, you're talking about 40 kilograms to 50 kilograms weight loss. So whereas with liposuction, you hardly get 1 or 2 kilos weight loss, and the fat is sucked from different areas. You get a change in the body contour. So you can get the excess fat removed from the tummy. You can get the fat removed from the arms or the thighs. So wherever there is excess fat, it gets sucked out. It's not a fully safe procedure because sometimes this fat can clog the blood vessels. It can cause fat embolism. So liposuction is not recommended for weight loss procedure.
Moreover, if I may add, Vijay,
Yes, sir, please.
liposuction is basically removing subcutaneous fat,
Yes.
and that can taper the change the balance of intra-abdominal to subcutaneous fat, because intra-abdominal fat is the cause of insulin resistance, while subcutaneous fat is something which maintains insulin sensitivity. So something which is not advisable, as you said, it is not a recommended procedure, and will not, unless some disfiguring part is there, a local fat deposition, that may be treated by it, but it is not a weight loss surgery as such. That is true.
Thank you, sir. Ajay, sir. So, what are the drugs available for treatment of obesity? So, we know that obesity, the most important treatment is lifestyle modification. But are there any drugs available for treatment? So, Milind sir, would you like to?
Yes, yes,
Uh,
yes. Okay. See, it is very important question that people in our area at least believe that drug is everything. If you have got diabetes, take anti-diabetic tablet. If you have got hypertension, take anti-hypertensive tablet. If you have malaria, you take anti-malarial treatment. So why not give something for obesity, anti-obesity treatment? But interestingly, if you see the history of anti-obesity drugs, it is studied with failures only. You start with fenfluramine. It was launched in 1995 or 6, I think. It had to be withdrawn within 1 year because of valvulopathies and primary pulmonary hypertension. Same thing with sibutramine. Same thing with locarcerins. Same thing with, I think, endocannabinoid derivative. What was that?
Rimonabant.
Riponamide. Riponamide produce more suicidal tendencies and whatnot. So, in short, there are many drugs which have been tried and withdrawn, tried and withdrawn. At present, we have got only two or three. I think, Ajay, you want to continue?
Yeah,
We have
yeah.
got which we can
Acha,
use.
I was having some net problem. Yeah.
Yes,
So
yes.
I think the various drugs, FDA approved drugs which are available. Generally, we are using three drugs. We are using orlistat most commonly. We are using GLP-1 receptor agonist. Either once a day or once a week. We are generally using the drugs which are available. They are acting by mainly two mechanisms. They are either they are preventing the absorption of fat from the GI tract, or they are inhibit or they are suppressing the appetite. One thing I want to add here is, generally, when once we start orlistat, say in the dose of 120 milligram 3 times a day, and in 3 months if it does not reduce 5% of the body weight, we should generally discontinue the drug. ऑर्लिस्टेट है ना, हमारे को पेट में से खाने को, कोलेस्ट्रॉल को एब्जॉर्ब करने में नहीं होने देती है. इफ द डाइट कंटेन one third of the cholesterol of the diet, or one third of the triglyceride of the diet is not absorbed. Generally, if you will see, if a person is taking for 1 year, it reduces 3 to 10% of the weight. Gen- Generally, lifestyle is very important part of weight management. And still if your doctor को ऐसा लगता है कि जैसे आपको joints का problem है, or you are having other comorbidities, then generally they are prescribing these drugs. The side 70% of the patients who are on orlistat are having GI problems, abdominal fullness या लूज स्टूल का उनको प्रॉब्लम होता है. And sometimes the loose stool problem is so much that they are not even able to control it. So when we are using these drug, we should tell everything advance in our patient. Another drugs which are available as daily you are giving GLP-1 receptor agonist, they are also causing 5 to 10% of your weight reduction. They are also having this side effect, and but you have to here give in large dose, say 3 milligram. And one newer drug, semaglutide, generally we are not taking the name, but GLP-1 receptor agonist we are taking weekly, it can reduce the weight even up to 15%. I think so. This new drug has come, and I think it is it is helping our patients. Only these are the three drugs I think is available. Generally a diabetic patients, when they are taking say metformin, it not significantly reduce the weight. It generally reduce 1 to 2 kg. But when they are combined with GLP-1 receptor agonist, say liraglutide, it is when it is combined, it can further reduce 1 to 2 kg of the weight. SGLT2 inhibitor also can reduce 2% of your body weight when we are using in a diabetic patient. So drug is, we are not having very powerful drug. Diet and exercise constitute a very important part, but still if your doctor prescribe you, you should take. And I think these are the safe drugs. You can take for a long time or lifelong also. You can take for a long life if it helps you. Thank you.
Thank you, sir. So there are a few medicines like injectables or oral treatment of diabetes, which along with treat obesity, as mentioned by Ajay sir. But you should definitely contact your or consult your endocrinologist before any of these medications are started. So moving on to the last question for today's session. Vijay sir did mention or gave a short intro about what weight loss surgery or bariatric surgery is in his discussion of liposuction. So Anis sir, would you like to tell our audience about the role of bariatric surgery in and obesity, and also how does this affect the lipid profile?
You are muted, Anish.
Sorry for that. Uh, Dr. Vijay had mentioned about these bariatric surgeries or the weight loss surgeries. Now, these are essentially a group of surgeries which, wherein you do a surgical changes to your stomach or to the digestive system, and they are broadly categorized into two groups. Again, it was mentioned restrictive varieties and the malabsorptive varieties. Now, what these surgeries do is one, they reduce the amount of food that a patient can eat. Second, they also cause some amount of malabsorption. Malabsorption means that whatever food the patient eats, most of it doesn't get absorbed, so that all those extra nutrients which contribute to calorie intake would not get absorbed, and that's how the patient tends to lose weight. Now, there are other mechanisms also which probably contribute to weight loss after a bariatric surgery with certain changes in certain hormones. But overall, what is seen is that if a person undergoes bariatric surgery, you can expect anywhere between 60 to 70% of loss of that excess weight. So, which is really very good, I would say. In fact, there is no other procedure as of now or no other medication as of now which can cause so much of weight loss. And bariatric surgery at this point of time is probably the most effective way of losing weight in those people who are, uh, I would say, whose obesity is little on the higher side. a term which we doctors describe as morbid obesity. So these are the group of people who have very high BMI, and for them, probably the only way to lose weight is to undergo a bariatric surgery. Now, I'm sure a lot of people have this thing in mind that I am putting on weight. Why can't I undergo a bariatric surgery? Because we do come across patients who are very conscious about their weight. Even a little amount of weight gain, they get worried. So we come across these patients who come to us who would have read about bariatric surgery on the net, and they feel that they would like to undergo bariatric surgery because it would help them to lose weight. But the issue here is that bariatric surgeries are, like, I would say, they are serious surgeries with certain issues which can crop up over a period of time, though they're relatively safe. But you cannot, advise bariatric surgery for everybody who's obese. That's something which I would like to stress here. Just because somebody is obese, somebody feels that they are overweight and they want to lose weight, they cannot be advised to undergo bariatric surgery. There are some very definite indications for doing bariatric surgeries. Now, in Indian context, what we say is if somebody's BMI is more than 37.5, Dr. Millen was talking about BMI as an index to define obesity. So we use the same index to define patients who will get maximum benefit from bariatric surgeries. So these are the patients whose BMI is more than 37.5. In some patients who have, let's say, diabetes or blood pressure or severe dyslipidemia or OSAs, even if their BMI is more than 32.5, they are candidates for undergoing bariatric surgeries. Other than that, somebody who's probably whose BMI is around 30, 32, who doesn't have other comorbidity, bariatric surgery is not the way to go. They need to probably look at what they eat and what physical activity they can pursue. Once a patient undergoes bariatric surgery and has that kind of weight loss, there is a significant improvement in a lot of parameters. A lot of comorbidities tend to improve significantly and in a very positive direction. For example, if somebody has diabetes, most of these patients go off their diabetic medications, they go off insulins, and many patients go into remission, what's called diabetes remission, wherein they can be non-diabetic, like without any medicines, without any insulin. Similarly, a lot of patients who are hypertensive can go off antihypertensive medications. Patients who are on lipid lowering agents can go off these medications. There are a lot of conditions like the OSA, where the patient has obstructive sleep apnea because of morbid obesity. There is a significant improvement in OSA because of bariatric surgery. In fact, it will probably correct it almost completely. And a lot of these patients can have a complete, I would say, resolution of obstructive sleep apnea. A lot of mechanical problems like osteoarthritis also seem to have improvement because of that significant improvement in weight. We're talking about 30 to 35 kgs of weight loss, and a lot of patients really do good. So, what I would like to summarize by saying is bariatric surgery is very effective when it comes to inducing weight loss, but there are definite indications for bariatric surgeries, and it's your doctor or your endocrinologist who can decide whether you're apt for candidate for undergoing bariatric surgery. It's not something which you can just decide at a drop of a hat. You need to go and plan things in a serious manner and then only go ahead with that. Thank you, Dr. Sajid.
Thank you, sir. Thank you, Anis, sir, for a wonderful description about bariatric surgery. Uh, so, to conclude, I would like to say that obesity means increased fat in the body, and obesity is unhealthy, period. Irrespective of the terms that we use of metabolically healthy obesity and whatever, obesity is unhealthy and it needs to be taken care of because it can lead to long term consequences like heart diseases, vascular diseases, in hypertension or high BP, diabetes, also psychosocial problems, etc. So, obesity needs to be taken care of, prevented, and you can take precautions regarding it. Also, women have increased risk of obesity and in turn the long term consequences of it. The most important cause of obesity is lifestyle. Some hormones do play a role in obesity, but that your endocrinologist will tell you. And mild variations in thyroid function does not cause obesity, and this everyone needs to know. So there are certain drugs available for treatment of lipid disorders as well as obesity. But again, this has to be at the discretion of your endocrinologist. And mainly, the treatment of obesity and dyslipidemia is lifestyle changes only. Surgical options also do exist, which cause a significant weight loss, but like it was discussed, it has certain indications. Like we said, it is generally used in uh, morbid obesity patients or otherwise at the discretion of your doctors. So you need to be cautious about your obesity. Consult an endocrinologist for a detailed discussion regarding the treatment of obesity, lifestyle changes, and everything. I hope all your doubts and queries were cleared by all the four senior endocrinologists that we have here. I would like to thank Milind sir, Vijay sir, Anis sir, and Ajay sir for a wonderful contribution. I don't think we have any I don't think
Sajal,
we
you're good.
have, yes, I don't think we have any questions from the audience right now. So, with that, we would like to end it. I really thank you all, sir, for a wonderful contribution.
Thank you.
Thank
Thank
you.
you.
Bye.
Thank you.
Thank you, Milind sir. Thank you, Anish. Thank you, ma'am.
Thank you. Thank
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 you,
you.
you.
sir. Thank you.
Yes, sir. Yeah.
Bye. Thanks.
Okay. Thank you. Okay.